Heart disease remains the leading cause of death globally. For decades, our primary defense against it has been tracking a metric known as low-density lipoprotein cholesterol, or LDLC, commonly referred to as bad cholesterol. But relying solely on this number leaves a massive blind spot in preventive medicine. A significant portion of the population suffers severe heart attacks, despite their lab results showing perfectly normal or even exceptionally low LDLC levels. This contradiction confused the medical community for years. It wasn't until researchers analyzed enormous datasets, tracking the health of hundreds of thousands of individuals over decades, that they identified a structural flaw in the standard lipid panel. The standard blood test measures the wrong biological unit. Instead of looking at cholesterol weight, a specific protein called apolipoprotein B, or ApoB, has emerged as the most accurate metric of cardiovascular risk. To accurately predict and prevent atherosclerosis, the medical field is realizing it must stop weighing the cholesterol mass floating in your blood and start counting the actual number of particles causing the damage. The underlying biology requires a transport system. Cholesterol is a fat, and blood is mostly water. Since fat and water don't mix, your body packages cholesterol into microscopic protein vehicles. Think of them as tiny submarines, to travel through your bloodstream. When we look at how coronary artery disease actually develops, the problem isn't the weight of the cholesterol cargo these submarines carry. The damage happens when the vehicles themselves crash into your arterial walls, penetrate the lining, and get trapped inside. The standard LDL-C test calculates cholesterol weight, ignoring particle count. A few large particles or a swarm of tiny ones score identically, but millions of tiny vehicles drastically increase arterial breaches. Every plaque-causing vehicle has exactly one ApoB molecule acting as a structural tag. Because of this strict 1-to-1 ratio, measuring the ApoB in your blood provides an exact, direct count of every dangerous atherogenic particle currently circulating in your system. Assessing true cardiovascular risk requires knowing exactly how many vehicles are crowding the road, rather than estimating the amount of baggage packed in the trunk. In clinical practice, the separation between particle weight and particle count is called discordance. This occurs when a patient's LDL-C test results completely disagree with their actual ApoB particle count. This clinical diagram illustrates how ApoB and LDL-C interact independently with the arterial wall. The most deceptive scenario is the bottom left panel, low LDL-C but extremely high ApoB. This high particle count drives steady plaque accumulation into the subendothelial space, tracked by the red arrows. This specific pattern frequently appears in patients dealing with metabolic risk factors, like obesity, elevated triglycerides, and insulin resistance or type 2 diabetes. An estimated 20% of the population has a discordance between their cholesterol mass and their particle count. Large-scale data shows that in every one of these cases, actual cardiovascular risk tracks with the particle count, never the weight. Advanced genetic research utilizing Mendelian randomization, along with global trials like the InterHeart study of over 20,000 individuals, confirm that ApoB is the most potent causal driver of atherosclerotic disease. This data table from the medical literature illustrates how modern science explicitly separates measures of lipid particle numbers, like ApoB, from traditional measures of cholesterol content, like LDL-C and non-HDL-C, to properly assess clinical risk. Major medical institutions are adjusting their protocols to match the data. The European Atherosclerosis Society has formally endorsed ApoB as a primary measurement for diagnosis and management, while the American College of Cardiology classifies an elevated ApoB count as a critical risk-enhancing factor. Checking this vital metric doesn't require advanced imaging or an expensive hospital stay. The ApoB test is a standardized, highly accessible, and relatively inexpensive addition to a routine blood draw. For anyone managing metabolic risk factors, relying solely on a standard lipid panel leaves too much to chance. Patients need to look past the top-line numbers and directly ask their physicians for an ApoB test. A normal cholesterol reading can easily hide a microscopic traffic jam in your arteries. Escaping that illusion is the required first step to accurately understanding and taking control of your cardiovascular health.